Oop, it says can't be reached. Let's try again.
Eva, it's live for me. I see
Oh, it
it.
is? Okay, it's giving me the site can't be reached. So as long as it's working, then we'll
Yep, it's good.
start. Awesome. Okay. So thank you for joining us today. My name is Hiva. You've probably logged into some other webinars in the past. If you haven't before, my name is Hiva and I'm with Archer Review. I'm a family nurse practitioner, board certified. I'll be talking to you today about diabetes. This is our part 2 of our endocrine lecture. We're going to go over all things diabetes. So we're going to talk about the different types of diabetes, specifically type 1, type 2, gestational, pre-diabetes. We're going to focus a lot on the medications and we'll do a lot of practice questions. So I know it feels like a big topic to a lot of people and it's understandable. It feels really overwhelming, but we're going to break it down. We're going to have fun. If you've done my webinars before, you know I like to keep it interactive. So keep your chat box open. We'll be doing some practice questions. Our lovely Miss Rachel is helping us with our chat today. So she'll be helping answer some questions. And then we'll have a lovely Q&A at the end too, where you can ask more in-depth questions based on what we talked about today, or just any general questions that you have about boards, Archer, diabetes, whatever's on your mind. So before we jump in, I want to bring to your attention that it is Nurses Week. So happy Nurses Week to all my nurses out there. And Archer is doing an awesome giveaway. So follow us on our social media page on Instagram to join the giveaways. They're doing like amazing things like Amazon giveaway, DoorDash, Figs, cards, gift cards, stethoscope. So it's lots of amazing things. I wish I could partake. So definitely follow us on social media and check those out. And then I also want to start with a quick poll that I'm going to launch. So just a few quick questions for me before we get started, but I want to know where you are in your journey. So are you still a student? Are you still studying for the boards? Have you sat for your boards? Let me know where you are in your journey. So take a quick 2-second poll. We'll leave that open and you can do those at the same time. So if you fill out the poll and then want to go in on our Instagram page and sign up for those giveaways, now's a good time before we jump in. So I'm going to give you guys a few minutes and then let everyone join as well. I'm going to give a few more seconds for the poll. Okay. So it looks like most of the people participating on our webinar today are graduated, and we have one still in school, so probably finishing up clinicals. Good luck. And then it looks like across the board, taking both exams, but maybe more ANCC, and some people are taking both. Good for you. That's ambitious. I actually do kind of wish I did that because why not, right? And then most of you had started some test prep questions, and some of you have not started. Okay, so I'm going to close out that board. Thank you so much for answering those questions for us. We like to know who's on and know our audience so that we can speak to your needs a little bit better. Okay, so let's get started. So like I said, this is part 2 of our endocrine system. Today, we're going to focus on diabetes. So specifically, we're going to be looking at the pancreas. But obviously, your endocrine system is a huge system. It helps regulate a lot of different hormones and chemicals in your body, tells your body what to do and when to do it. So it's a really important system to get familiar with. And today, we're going to focus on the pancreas. So a quick little overview about glucose metabolism. I know you already know this, but just keep in the back of your mind as we're going through today's lecture. As we eat the food that we eat, our body takes those carbohydrates and turns into glucose. That glucose goes into our bloodstream, and then our pancreas then releases insulin to help get that glucose into our body's cells, right? To give the body, the cells, the energy that they need. The liver also helps release some extra glucose into the bloodstream as needed, and they both work together to help maintain homeostasis of the insulin levels and the glucose levels in our blood. So that is normal pathology, right? So let's talk a little bit about abnormal. There are two main types of diabetes mellitus. There's type 1 and type 2, which you're probably familiar with. Type 1 is that autoimmune response. So the body has destroyed the insulin producing cells, those beta cells in the pancreas. And so that patient is going to require insulin. Sometimes they might have the pancreas still producing some insulin. Sometimes they don't have the pancreas producing any insulin at all. So you'll see some variation there. And that's about 10% of all cases of diabetes mellitus. And then it's most common in childhood. So we'll talk a little bit about that as well. And in type 2, it's more metabolic dysfunction, right? So you're seeing more insulin resistance, insulin deficiency. Once that pancreas gets really tired, it might not be producing as much insulin, but you're seeing more insulin resistance. And that's about 90% of our cases of diabetes. And that's probably what you're going to be managing more in the outpatient primary care clinic, unless you choose to go into endocrinology. And we'll talk more about that as well. So signs and symptoms are the same for both type 1 and type 2. You're going to see increased urination, increased thirst. So let's break that down a little bit and talk about why you see these symptoms. I think most people just memorize the symptoms, but I want you to understand them so that you know what's happening in the body. So why are we seeing increased urination? So as those blood glucose levels go up, your body's really trying hard to get rid of the glucose, right? Because
Hey,
it's not
we
going.
don't see your slides. Sorry.
Oh, okay. Sorry.
I don't
Let's
know
see.
why they're not sharing.
Hmm. So I'm flipping through, you're not seeing them at all?
No, I'm not.
Hmm. About now.
No, I don't see them. Are you sharing your screen? Weird.
That is weird. Let's try this. Hmm. I just did it again. Can you see them now? Can you guys see them now?
Yep, now they're up.
Oh, bummer. Okay.
That's
Sorry about that, you
okay.
guys. Well, it's okay. There was this QR code while we were doing the poll. And then we talked about the endocrine system. We're focusing on the pancreas and then just that glucose metabolism overview. And then we're just talking about type 1, type 2. Okay, thank you. I appreciate that. Sorry about that, gang. Technical difficulties, what can I say? Okay, so we were talking about the difference between type 1 and type 2. So like I said, signs and symptoms are pretty much the same for both. And why is important. So as those blood glucose levels go up, your body's trying to get rid of the blood glucose. So it's going to urinate or excrete it through the kidneys, through the urine. And then with that, it's going to pull a lot of water. So you're going to have a lot of increased urination. And then obviously that patient's going to need to rehydrate, so it's going to increase the thirst, right? And then you're going to see probably some genital itching, thrush, because as that glucose is coming out, that's going to create a nice warm body or bed for the, overgrowth of yeast or urinary tract infection. So the reason why I want you to understand all this is because when you're seeing patients coming in with frequent UTIs or they're complaining about increased thirst, you want to kind of have in the back of your mind of what could be causing this, right? What's going on with the pathophysiology that could be causing it. So if someone's coming in with a lot of frequent yeast infections, you might think, I wonder what their blood glucose levels are, right? Also with the slow wound healing, the reason for that, again, because there's a lot of glucose in that blood. So it's going to be a warm bed for bacteria to grow in those wounds. So it's going to be really slow wound healing. And then blurred vision. Why blurred vision? Because actually there could be a buildup of glucose in front of that lens. So the patient's going to develop blurred vision over time. Tiredness because the cells are not getting the energy that they need. So remember, the glucose is not getting into the cells, whether there's not enough insulin or it's just not working properly. There's insulin resistance. The cells are not getting what they need. So that patient's going to feel a lot of fatigue. And then you might see initially some weight loss. So the body's going to try to compensate by breaking down some of the adipose tissue to try to get that energy to the cells. So you're going to see weight loss and, of course, increased hunger as they're losing weight because the body's going to need more and more energy. So you can see how this cycle kind of continues, right? So typically you'll see this in your patients who are undiagnosed or they have uh, high blood sugars that are unmanaged. You're going to see more and more of these signs and symptoms, and you're going to want to ask about these signs and symptoms when you see those diabetic patients in the clinic. So then diagnostics. So how do you determine between type 1 and type 2? So the first step is to determine the patient has diabetes, right? And you can do that with an A1C over 6.5. You can do that with a fasting glucose over 126. 2-hour plasma glucose over 200, a non-fasting over 200. All those can be diagnostic of diabetes. Once you've made the diagnosis of diabetes, then the next step is to distinguish whether it's type 1 or type 2. There's no set criteria for diagnostic tests to distinguish between the two, so you're going to have to look at the global picture. You're going to have to look at the clinical presentation, the history, and then there are labs that can help support your diagnosis. So specifically, I want you to know about pancreatic autoantibodies. Whether you'll be the one ordering these or not is up to you, but this will be something that will be managed by a pediatric endocrinologist. So I wanted to point these out so you're aware of them. But for the purposes of the board, they want to make sure that you're practicing safely. So you want to make sure you don't practice beyond your scope and you're getting these patients to the right care and the right specialist. So those pancreatic autoantibodies can help confirm the diagnosis of type 1 diabetes. So in a patient with type 1, they'll have one or more of those pancreatic autoantibodies, which indicates the destruction of the pancreatic beta cells. Also, you can check the serum insulin levels and C-peptide levels, and those will be low in a type 1 diabetic patient. They'll be high in a type 2 diabetic patient. And then you also want to look at age. So type 1 diabetes is more prominent in early childhood. So it peaks around ages 4 to 6, but typically before ages 10 is when we're going to see it. And then in type 2, we are seeing type 2 in childhood as well. So type 2, you want to think about that as onset of puberty comes on if they're starting to show symptoms. So focus on demographics when they're asking you in the boards, just so you can get a clear picture of what are we looking at? Is it more likely type 1 or type 2? And then also body habitus. So you might initially see some weight loss in both, but really that type 1 diabetic child is going to have more of an acute history of weight loss, and that type 2 diabetic child is going to look more overweight and obese. They're probably going to have some other signs and symptoms of insulin resistance like acanthos nigrans, PCOS, hyperlipidemia, hypertension. So it's going to look like your typical type 2. And then also family history is really important. Are there other autoimmune conditions in their family history? Are they more at risk for type 1 diabetes? So remember, once you have one autoimmune condition, you're also at more risk, increased risk for other autoimmune conditions, and family history is the same. So if you have a parent with type 1 diabetes, that's important to know, or just any family history of type 1 is important to know and ask about. So let's practice. What is it going to look like on the boards, right? So this could be something that they might ask. So the family nurse practitioner is planning care for a 4-year-old patient that came in with symptoms of diabetes mellitus, confirmed with an A1C of 8%. So normal A1C, it's giving you that. So it wants you to tell them what's the next step in the management. So which of the following is the most appropriate next step in management? And remember, they're trying to determine safety. So is it A, begin lifestyle changes and treatment with metformin? Is it B, urgent referral to pediatric endocrinology? Is it C, collaborate with a pediatric physician? Or D, set up nutritional consult? And I'll give you guys a few minutes to answer in the chat box. Good. I see a lot of participation today. You guys are doing great. So if you said B, you are correct. So they again want to make sure that you are practicing safely, right? So in a patient, again, 4 years old, so type 1 diabetes peaks between ages 4 to 6. So they gave you a 4-year-old, clearly with a high A1C. So diagnostic is there for diabetes. You're suspecting type 1. What are you going to do next? You're going to send them to a pediatric endocrinologist to get them on insulin, right? So that's going to be the safest thing that you need to do next step. So why was A incorrect? Insulin will be required, but the treatment should begin immediately. So in A, it said begin lifestyle changes. Metformin's not going to help that patient with type 1. So they do need insulin. That's not appropriate. Why is C not correct? So yes, you would be collaborating with a pediatric physician, whether you're in a state that requires a supervising physician, or if it's a complicated case and you're consulting a colleague, but that's not going to get them the care that they need. They need to see a pediatric endocrinologist to start the insulin therapy. And then same with nutritional consult. So that's going to eventually come, right? They definitely need to see nutritional consult to talk about what their eating habits are like, carb counting, insulin management. So diabetes educators are awesome and they're going to be very helpful, but that's not going to be your next step after you identify this patient has diabetes, likely type 1. So very good. So the boards are going to focus on safety. They're not going to expect you to manage type 1, but they want to make sure that you can get them the care that they need right away. So let's talk a little bit about pre-diabetes. So we know our hemoglobin A1C levels, normal is less than 5.7%. Pre-diabetes is 5.7 to 6.4%, and diabetes over 6.5%. So pre-diabetes, why do we care about pre-diabetes? Well, it's the first sign of insulin resistance that we're seeing, right? So our job in primary care is prevention, prevention, prevention. If you've listened to my webinars, you know I like to say that a lot. So primary care is prevention, right? Preventative care. So you want to talk to your patients. If you're starting to identify some of these risk factors, you want to talk to them about what's happening with their body and what it could lead to down the line. So we have modifiable risk factors. So if your patient is overweight or obese, that's going to cause more insulin resistance. As they age, they're going to have more insulin resistance, lack of physical activity, excessive caloric intake. So all these risk factors are some things that we can work on to help prevent diabetes, right? And then, of course, there are non-modifiable risk factors. So you do want to ask family history. Sometimes the genetics play against the patient, even if they are trying hard with the physical activity and the diet. Race, ethnicity, all that can play a role. So you definitely want to talk to your patients about what you're seeing in the clinic and assess their risk factors and try to prevent diabetes, right? There's also gestational diabetes. So depending on what kind of practice you started in primary care, you may or may not be seeing your OB patients. But typically, we do screen our OB patients for gestational diabetes between 24 to 28 weeks of gestation. They use usually an oral glucose tolerance test, either at 1 hour, 2 hour, 3 hour. Most OBGYNs do a 1 hour screening. And if the patient fails that, then they'll follow up with a 2 or 3 hour screening. And there are different diagnostic criteria that they'll follow for that. So how would that look on the boards for your gestational diabetes patient? So the nurse practitioner is reviewing lab results for a 24-week pregnant patient. The result of a 1 hour glucose challenge test is 140. So they failed that, right? Which of the following is appropriate in making a diagnosis? So is it A, order a 3-hour glucose tolerance test, B, order a hemoglobin A1C, C, review fasting and 2-hour postprandial blood glucose levels, or D, diagnose gestational diabetes? So go ahead and put what you think in the chat box. Good, you guys. I'm seeing a lot of participation, and I don't care if it's right or wrong. I just want to see participation because this is the time to get it wrong. On your boards is the time to get it right. So if you said A, that is correct. So you would follow that up with a 3-hour glucose tolerance test to make the diagnosis of gestational diabetes. So why was B incorrect? So the A1C was helpful, but that's not really the recommended way of diagnosing. It's more for management. And then C is a little tricky, so I'll go back to C. So review fasting in 2-hour postprandial. So it could have confused you because you could have thought, oh, that's a 2-hour glucose tolerance test or reviewing fasting. So you're likely not going to have that information if that patient is not a diabetic anyways. So it's really repeating that 3-hour glucose tolerance test. And then you wouldn't make the diagnosis with gestational diabetes quite yet. You definitely want to make sure you confirm by repeating that test, right? So that 1 hour is just a screening test, and then you want to actually make the diagnosis based on that 3-hour. So awesome job. So diabetes type 1, as we talked about, management is going to be pediatric endocrinology, and endocrinologist is going to manage that unless you choose to go into endocrinology. They will need to see nutritional counseling to talk about carb counting, and they do require insulin. So they're going to need basal insulin on board. They're also going to need prandial insulin, and they'll help the endocrinologist team will help them come up with a schedule for that, teach them on all those things. They do have a lot of amazing devices now. So they have continuous glucose monitors called CGMs that patients can wear. It goes right to their phone. They can know their blood sugar at any time, sets alarms for them. It's really great. If you have a chance to play around with one and wear one for a couple of weeks, you should definitely do it because you learn a lot about your body and your blood sugar and how it reacts to food. So they have a lot of awesome devices at endocrinology practices. So you want to definitely make sure that you get them to that endocrinology team so that they can give them the things that they need to help manage their blood sugars, right? And they have a lot of different types of insulin pumps now too, so that talk to the CGMs, and it's getting a lot better for type 1s living with type 1 diabetes, especially our younger kiddos where they don't really have the bandwidth to manage that condition quite yet. It's really helpful to the families. So getting them the right care they need, the right devices is going to be really important. So that's your type 1. So let's throw another practice question out there. So a patient with type 2 diabetes mellitus has been taking oral medications, but their hemoglobin A1C remains elevated, 9.5%. So remember, they've done oral and their A1C is still not controlled. The patient weighs 199 pounds. The nurse practitioner is starting insulin, so they want to start Lantus. The nurse practitioner will correctly dose this as which of the following? So is it A, start with 5 units BID, so breakfast and bedtime? Is it 5 units before each meal? So this is Lantus we're talking about. Is it 10 units sub-Q every 24 hours? Or is it start 18 units sub-Q every 24 hours? So go ahead and put what you think in the chat box. Okay, this was a really tricky one, but the reason why I put it in here is because even if you're not expected to be managing those type 1 diabetics, you will have questions about insulin on the board. So understanding how to start someone on insulin is most likely going to be your type 2 diabetics who are not well managed. It's going to be helpful for you on your boards as well as in clinical practice. So just knowing the basics is going to help you, so you could eliminate other responses by just knowing the basics. So Lantus is long acting, and so when you're starting somebody on Lantus, you first of all would never start them BID. So it's not something that you take morning and night, just once a day. And then you also would not take it at mealtime. It's not a short acting insulin, right? So you would automatically eliminate those two. And then the other thing, so you're left with, do you start them on 10 units a day or 18 units a day? So if you did the calculation, if you knew the calculation, you would know that they would eventually need 18 units a day. But that's way too much insulin to start somebody on, and you don't want to start somebody on more than 10 units a day to start, and then you would slowly titrate up because you don't want to risk hypoglycemia, right? Their body's going to have to learn to adjust to the insulin that they're using. So typically, and sometimes I won't even go as aggressive as 10. I'll start patients on even lower amounts of insulin and gradually go up, but you can increase their insulin by 1 to 2 units every 3 days until you get to their target fasting glucose in the morning. So just knowing those things, you didn't even need to know how to calculate it, but what you need to know is definitely D is too much insulin to start somebody on right away. You would not be doing it at mealtime because it's Lantus, it's long acting. And then you would not be doing it BID because again, it's Lantus, it's once day dosing. So automatically you know it's likely C, right? And then now you also know that you likely will not, for safety reasons, would not start somebody on more than 10 units a day and you would gradually titrate up. So definitely important to practice those test questions, right? You learn a lot from the rationales. Okay, so type 2 diabetes, let's get into that because there's a lot of medications and I know everyone's nervous about them, but we're going to break those down too. And again, we're going to go through some practice questions to make it stick, hopefully, in the brain. But basically for type 2 diabetes, you have two different main sources for guidelines that you can use for the management of type 2. You have the American Diabetes Association, the ADA, and you also have the American Association of Clinical Endocrinology, which is called ACE. So those will be really helpful when you're first getting into practice and you're trying to figure out where to start the patient. We're going to start with talking about sulfonylureas. So those are your glyburide, glipizide, glimepiride. So as we're going through the medications, I'm going to highlight the things that you should know about the class of medication, and that's going to help you with your boards because you want to make sure, again, they're going to be asking you safety questions. You want to make sure that you know when you're prescribing something, what are you monitoring for? What is the safety of that medication, right? So with the sulfonylureas, the biggest thing, the biggest side effect is hypoglycemia, and that's what you're going to be monitoring for. And that's why they've kind of fallen out of favor with clinical practice just because of the hypoglycemic effect. And then it also does cause weight gain, which patients really don't like. But the pharmacology behind it's important too. That'll also help you remember. But the pharmacology for sulfonylureas, it helps increase the release of insulin from those beta cells. So of course, you can't use that in a type 1 diabetic if they have destruction of those beta cells, right? It also affects the insulin metabolism in the liver. It decreases the glucagon secretion and increases the insulin sensitivity. So it is effective, but you do want to watch for hypoglycemia and then always start with initial dose really low, see how they do. You will take it with meals, so you want to educate patients on that because you want to avoid hypoglycemia. And then you can gradually increase over the course of 1 to 4 weeks, and then make sure you don't hit that maximum dose because I rarely use that maximum dose. So you definitely want to avoid hypoglycemia in your sulfonylureas. And then, of course, you can't use this in your patients with pregnancy, breastfeeding, so keeping those things in mind, right? And then your thiazolidines, I always mispronounce that, but it's your glitazone. So if you look at the end sounds, it's your glitazone. So that's your Avandia and your Actos. These medications work by sensitizing the body's reaction to insulin. It also affects the glycogenesis in the liver. So for this one, what do you need to know? You need to watch for heart failure, right, in this class of medication. So you would not start this patient with class 2 to 4 heart failure on this medication. So that's something that might come up on the boards. Biggest side effects are fluid retention, heart failure, weight gain, again, with these class of medication. And so if your patient's starting to develop signs of heart failure, rapid weight gain, shortness of breath, lower extremity edema, you want to hold, discontinue, or decrease the medication and investigate further and make sure that they have not developed or worsened in their heart failure. So again, remember the big topics for the class because that's what's going to happen. That's what's going to come up on your boards. And then so metformin, my favorite diabetes drug. Patients seem to hate it, but I seem to love it. So metformin helps by reducing the hepatic output of glucose from the liver. It also helps decrease the absorption of glucose in the intestines. So that's why you get all those GI symptoms that patients don't like. And then it also helps increase the uptake of the glucose in those peripheral tissues. So it helps on that cellular level with that insulin resistance, right? So that's why I love it. It works on a cellular level with that insulin resistance, but patients really don't like metformin, especially if providers start them on like 1,500 or 2,000 milligrams a day. Please go slowly with this medication and allow your patient the opportunity to stick with it, right? So if you start with a high dose, they're going to have really bad side effects. They're going to have loose stools, stomach pain, nausea, and they're going to continue the medication. But if you start with just 500 milligrams a day, make sure they're taking it with their biggest meal of the day, and then gradually titrate up as they tolerate it over the course of 1 to 4 weeks. You can go up by 500 milligrams at a time. And you don't have to go to the maximum 2,000 milligram dose. You can stick to 1,000, 1,500. There's no clear guideline on the benefit of how high to go on metformin, but as long as you have some metformin on board, I'm happy with that because it really is a cheap medication. It's a safe medication and it works well. You do want to watch for renal impairment, and then there is the risk of lactic acidosis. So those might be things that come up on the board. But generally, metformin is going to be your first line with your type 2 diabetics. Getting your patients on metformin, even in that pre-diabetes phase, is going to help so much with their insulin resistance and helping them stick to it as they stay on this medication. Those side effects do subside. So encourage them really to stick with it. Okay, so let's practice. So in planning pharmacologic treatment for a geriatric patient with diabetes, which of the following should be considered? So are you going to start them on a sulfonylurea as first-line therapy? Is it going to be Lantus as first-line therapy? Are you going to start them on a combination of a sulfonylurea and metformin as first line? Or are you going to stick with just a single medication therapy, metformin? What are you going to do first? And this is your geriatric elderly patient. Good. I love it. I love the participation, and you guys are listening. See, these meds aren't so bad, right? So D is correct. Metformin would be your first line, and you do want to watch for renal impairment. So, of course, in a geriatric patient, you want to look for any signs of end-stage kidney disease, but generally, this is a really safe medication, and it is first line. So always start them on the metformin, go slow, and see how they do. You would not start them on sulfonylurea because, again, of that hypoglycemia side effect. So it's the geriatric patients are already at increased risk, so you want to be really careful with that. You also wouldn't start them on Lantus, again, risk of hypoglycemia, and it's not first line. And then you also would not start them on a combination, right? Not first line. You always want to start with one medication, see how they do, and then always add a second if they need more help. But you're able to eliminate those other answers based on your knowledge, right, of those medication classes. So you're doing great. All right. So SGLT2 inhibitors or your gliflozins. So that's going to be your Invokana, Farxiga, Jardians. Those are going to be more popular names that you're going to see, brand names. So how do those medications work? They decrease the absorption of the glucose in the kidneys. They're mostly working in the kidneys. They reduce that renal threshold for glucose. So then they promote a lot of glucose excretion in the urine. So of course, side effects are going to be increased urinary output. That's going to be a normal side effect of these SGLT inhibitors. What you want to watch for in these patients, because that glucose is just your body's urinating that glucose out. Again, what we talked about in the beginning of the lecture, you want to watch for yeast infections, urinary tract infections, because that glucose creates a nice warm breathing ground. So you want to watch for that. You also want to watch for signs of hypovolemia. So you wouldn't start these medications in your elderly patients that may already be at risk, or if they're on other medications that could worsen their hypovolemia, right? So you want to be really careful with that. So watch for dehydration, watch for infection. These medications also can be helpful in weight loss, so that might come up too. And then you also want to look at their electrolytes while they're on this medication. So typically when they come to the office, if you have this patient on this medication, you'll grab a urinalysis, make sure there's no sign of infection. You'll also probably periodically be checking their chem panel, making sure their potassium levels are normal, their sodium potassium channel levels are normal. And then following the dosing instructions and not being too aggressive, especially in those geriatric patients or patients already at risk for dehydration. And then your GLP-1 agonists, so those you've heard a lot about, I'm sure, and you're going to continue to hear a lot about these because These are the quote unquote weight loss approved medications that patients come in and talk to you about. This is your Victoza, Trulicity, Ozempic, Wegovy, Mounjaro, Zepbound. So Ozempic, Mounjaro, those are the ones approved for type 2 diabetes, and they've come out with their new weight loss approved versions, Wegovy and Zepbound. The way these medications work is they stimulate the release of insulin by the islet cells. They do help slow with that gastric emptying. So again, you're going to get a lot of GI symptoms with this medication. And then it does inhibit the release of glucagon postprandially, and it reduces the food intake, so food appetite suppression as well. So it really is effective with weight loss. There is use for it in the clinic, but you have to be really careful. There is a risk of thyroid C-cell tumors. So they've seen it in rats. It's undetermined in humans, but in someone with a family history of medullary thyroid carcinoma or a personal history, you would not be using this class of medication. I'd also be avoiding it in patients with gastroparesis or any kind of delayed gastric emptying, just because it does predominantly work by slowing the gastric emptying, and you don't want to further put them at risk for pancreatitis, which is already one of the black box warnings. And then you want to follow the dose instructions. So you want to start slow, again, let them adjust to the side effects, and then slowly titrate up as tolerated. With these patients, what I really emphasize if they're taking it for weight loss is making sure that we're doing the dietary and nutritional piece with it, because that's going to be really important to make sure that they're losing fat and not muscle tone. So if patients don't do the work with the exercise and changing their dietary intake, we're seeing more and more cases where they're losing more muscle mass than fat, and patients are worse off than when they started on these medications. So you want to be really careful with patient education before you start these medications on patients. And if they need that help with nutrition, get nutrition involved. If that's a resource that's available to you either in your practice or your community, that's going to be really helpful. So educating these patients on these medications. I love when they come in and ask for the GLP-1s because they can't tolerate the metformin. They both have the GI side effect, but patients seem to want to tolerate the GLP-1 because they see that weight loss, that immediate weight loss with the GLP-1s versus metformin. So try to get your patients on metformin first line. Use this as additive. If you're talking about using it for weight loss, make sure you're talking about doing the lifestyle modifications along with it, right? Excuse me. And the DPP-4 inhibitors, those are your gliptins. So that's your Januvia, your Tradjenta. That helps improve insulin response to glucose intake. It reduces the glucagon concentration, also slows the gastric emptying, increases that GLP-1 activity. Side effects, you're going to see some nasopharyngitis, headaches, and it is contraindicated in heart failure. So again, safety questions on the board. And then you want to also watch for signs of pancreatitis. So follow the dosing instructions, but for the boards, safety, 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 you're probably going to make sure that you're not starting this medication on a patient with heart failure and you're watching for signs of pancreatitis. Okay, so let's practice. A patient presents with a desire for medical management of weight loss. So they're coming in for weight loss. The patient has been working on diet and lifestyle, good, but has not had much success and is trying to improve type 2 diabetes mellitus. So they do have type 2, right? And they're working on the weight loss, but they're working on the diet, they're working on the lifestyle modifications, but they're not having success. So which of the following diabetic drug classes may be helpful? And you can select all that apply. Is it your TZDs? Is it your GLP-1s? Are you going to start them on SGLT2 inhibitors or sulfonylureas? So go ahead and put your answer in the chat. And I'm sorry, I'm getting more and more stuffy as the lecture goes. I apologize. Cold of the spring season, I guess. Okay, so it looks like a lot of people are saying GLP-1s, good. Just a general test question advice. When they say select all that apply, oftentimes they do want more than one answer. So I see some people said B, some people said C. So if you said B and C, you're absolutely correct. So why is that? Because both these classes of medication are helpful in weight loss. That's part of the side effect with the GLP-1s and the SGLT2s. The TZDs and the sulfonylureas actually have weight gain as side effects. So again, knowing those side effects for the class of medication, you can hopefully rule in and rule out some answers. Awesome. So moving on to our meglutide analog. So that's your Prandin and your Starlix. Again, we do see this in some patients also falling out of favor because of that hypoglycemia, but it does stimulate the release of insulin from those beta cells. So you would have the patients take it with meals, and it helps with that preprandial and that postprandial hyperglycemia. But hypoglycemia is a potential side effect, so you want to watch for that. And then, of course, it's contraindicated in type 1 diabetics just because it is releasing insulin from those beta cells. So again, the mechanism of action is not going to be helpful in those type 1 diabetic patients. With the dopamine agonist, so your bromocriptine. So truthfully, this medication is for hyperprolactinemia, and it has been approved for the treatment of type 2 diabetes. Generally, this medication is not tolerated very well, so I don't see it used very much for type 2 diabetes management, but it doesn't mean that an endocrinologist or specialist would not use it in that way. I don't think you would be using it this way in primary care, but you should know about this medication. So it does stimulate the central prolactin activity in the pituitary gland. It's reversal of insulin resistance. It decreases glucose production and does not increase serum insulin concentration. And the biggest side effect, the reason why patients can't tolerate it is most of the time the dizziness and the headaches. They might have some GI symptoms like nausea, constipation, some nasal congestion, but you're going to see that orthostatic hypotension because of the dizziness and the headaches. And you would start really slow with this dosing, 0.8 milligrams just in the mornings. Again, it's the way it works, the mechanism of action. You want them to take it in the morning. And you can increase it weekly, but most of the time I'm not seeing patients on this maximum dose because they really can't tolerate the side effects. And these are in patients with hyperprolactinemia. But it is approved for insulin resistance and type 2 diabetes. So you might see it. Your alpha glucosidase inhibitors. So this is your carbose and your miglatol. So they do inhibit glucose absorption in the small intestines, decrease in the rise of postprandial glucose. So you want patients to take this at first bite because it works in that small intestines. You're going to have those GI symptoms. You also want to look for increased LFTs. You would not be starting this in a patient with liver or renal impairment. And you're going to follow those dose instructions accordingly. And then your bile acid sequestrant, so like your Welchol, this class of medication was developed for the treatment of hyperlipidemia, and that's where you're going to see most of the time it's being used. But they did note the effect of the glucose lowering effect that it had, so then it was approved for type 2 diabetes. It's actually the only medication in this class approved for type 2. Again, I don't see it used very much for type 2, but if a patient's already on it, maybe they do have hyperlipidemia, you could put them on Welchol and it could have an effect on both. Could be really helpful. So it does work with the glycogen synthesis, the glyconeogenesis, promotion of insulin secretion, lowering of the blood glucose. It does have GI side effects, and the contraindication is avoid it in patients with triglycerides over 500, or if they've had a history of pancreatitis or bowel obstruction, and then follow the dosing instructions there. And then lastly, we have amylin class of medications like your Simulin, and that is a injectable, and it helps with slow gastric emptying. It suppresses that glucagon and regulates appetite. And again, the biggest side effect is going to be hypoglycemia. So again, watching for hypoglycemia, making sure your patients have hypoglycemic awareness, and then follow those dose instructions. But it is approved for both type 1 and type 2 based on the pharmacology and how it works. But it'll be a sub-Q injection with meals. So overall, management of type 2 diabetes, you have your non-pharmacologic management. So those are your lifestyle modifications. We really want to work with patients on that because we want them to make sure they're eating well, getting enough protein, watching the carbohydrates. and then also exercising. So the more we can get them to lose weight and exercise, the better it's going to be on that insulin resistance. And so lifestyle modifications are going to be our number one, both prevention and helping with management. And then their goal of A1C, less than 6.5% in a young, healthy individual with type 2 diabetes. But in your elderly patients, you want to pull back a little bit. And we'll talk a little bit about that with an exam question example, but you want to make sure that you're not being too aggressive in your elderly patients because it's going to be actually more risky for them to have hypoglycemia than have a little bit of hyperglycemia. Of course, you don't want them in DKA or anything like that, but if they have, A1C levels 8%, 8.5, that's perfectly fine. You don't want to be too aggressive in your elderly patient population. So just be really careful with that. And the exams are definitely going to ask you safety questions about that as well. And you probably remember that from your polypharmacy courses. And then for pharmacology, again, metformin. I love metformin. You got to talk your patients into metformin, but it's worth it. Try to get them to stick it out, start low and go slow. And then the secondary drug classes that we talked about today, you can use the guidelines to help you, but looking at patients on an individual level and trying to figure out what makes the most sense for them as an additive secondary agent is going to be the most helpful. And then when do you refer? So if you have a patient, you've been trying a lot of oral medications, maybe you've gotten them started on Lantus, I think it's time, or a long-acting insulin, I think it's time to help bring in a specialist to take a look and see if there's other things that they could do. Like I said, the specialists have a lot of different devices. They have access to CGMs, which are those continuous glucose monitors. They have access to a lot of samples, things that you don't normally get in primary care practice. So if you're having a patient that's just doing what they can with lifestyle, they're doing what they can with oral medications, and you're just not getting their A1C to goal, then maybe it's time to refer out. And then so potential complications that we want to talk about with our patients. So educating our patients is the number one priority because our main job in primary care is preventing these complications. So ideally preventing the diabetes. If they've developed diabetes, preventing the complications that come with diabetes. Over time, high blood glucose levels can cause damage to the tiny blood vessels, the microvasculature. And so part of that could be damage to the eyes called retinopathy, which can lead to blindness. So making sure they're getting in their annual eye exams is going to be really important. If you're really good at your fundoscopic exam, that's great. But in primary care, you're realistically not going to have time to be doing fundoscopic exams. And you want to make sure that they're seeing an ophthalmologist to get their annual eye exams and getting a diabetic eye exam, which looks at their retina and looks more in depth to look for any early signs and detection of retinopathy and treats it right away. You're also going to look for signs of neuropathy. Patients might come in complaining of sensation, decreased sensation, or that numbness or tingling in their extremities, but hopefully you're preventing the neuropathy by helping keep their blood sugars at goal. But if they have developed neuropathy, nerve damage, you may have to help them with the symptoms by treating it with medication like gabapentin, Lyrica, Cymbalta. You also want to try to avoid those diabetic foot ulcers. So the combination of poor blood supply and nerve damage can lead to ulcers. And then we want to avoid infection and worst case amputation. So talking to your patients about foot care is going to be really important. And then don't be afraid to send them to podiatry if they have like really bad foot care. They're just not doing what you're asking them to do and they need extra help. Podiatry is there for you to be a support. So don't be afraid of referring those patients to podiatry. They really could benefit from it. I'm thinking of some gross feet. Nephrology. So we definitely want to make sure we're watching kidneys in our diabetic patients, right? So both the afferent and efferent and the glomerulus can get damaged with high levels of blood sugar, which can lead to kidney damage over time. So we want to avoid that. And the best thing to do is to screen them annually with that urine microalbumin and making sure we're keeping those blood sugar levels at goal. And then erectile dysfunction, you may have some patients come in who disclose that to you. You may want to make it part of your routine to ask about erectile dysfunction. But basically the biggest thing is prevention by having good glycemic control and good blood pressure control. It's the best preventive measure. And then if they are experiencing erectile dysfunction, they may need hormone replacement, testosterone. So either your practice or you want to send them to urology or endocrinology to help them with that symptom is going to be helpful at all. So educating your patients is going to be number one and helping prevent those complications. Diabetes also increases the risk of medium to large arterial wall damage, right? So like atherosclerosis, heart attack, stroke, they're major contributors to morbidity and mortality in our diabetic patients. So we want to definitely make sure we're screening those patients. We're checking their A1Cs regularly. We're looking at their lipid panel as well, right? Their chem panel to look at their kidney function, electrolytes. We're doing a urine albumin every year to look for those early signs of kidney damage. I like to get a baseline EKG on my patients, especially past a certain age, just to make sure that we don't see any EKG changes on there. If they're smokers, if you listen to my cardiac lecture, you know that's the biggest risk factor. So trying to talk to them about smoking cessation at every visit. They might not be ready the first time or the second time or the 10th time, but maybe by the 20th time, they'll hear you. And then making sure you're getting those annual eye exams and the foot care. So again, preventing those complications is going to be really important. I also want to throw in a quick slide about DKA versus HHS. I know that we're talking about outpatient primary care, so we're not talking about inpatient nursing care. You probably remember this from your nursing boards or what you do if you're inpatient or outpatient, you might deal with this. But basically, both DKA and HHS are severe hyperglycemia. Knowing the difference between the two is good for your knowledge, but what they're probably going to try to identify on the boards is making sure you're getting the patient to the medical care that they need. So in both cases, the blood sugar levels are going to be high. In DKA, blood sugar levels are most likely over 300. They're going to have ketones in their urine and their blood. They're also going to have systemic acidosis, maybe some hyperkalemia, and that develops more urgently over hours to a couple of days. And it's more common in our type 1s, so we're also seeing it in our type 2s as well. And then in HHS, also severe hyperglycemia, but again, more like blood sugars over 600, and you don't get the ketones or the acidosis, and that's more slow developing and more typical in our type 2 patients. But the biggest thing I wanted to convey with this slide is that the treatment is they do need to go to higher level of care. So they're going to need IV fluids, IV insulin, frequent blood sugar checks, and treating the underlying cause is going to be really important. So on the boards, when you're looking at a test question, you want to figure out, is this a safety question? Are they trying to get me to diagnose DKA versus HHS, or are they trying to get me to diagnose, or what's the next step? Where does this patient need to go? And that's going to be to the hospital, right? So again, safety questions are what the board is going to, they just want to make sure that you're practicing safely. And then both for the boards and for your clinical practice, hypoglycemia, we talked a lot about this. So especially with your patients who are on insulin, are on medications with hypoglycemia being the risk factor, you want to make sure you talk to these patients about what hypoglycemia is, have some hypoglycemia awareness, and make sure you have a game plan so that they know what to do when they do notice signs and symptoms of hypoglycemia. And if they're checking their blood sugars, they see that their blood sugar levels are too low. So blood sugar levels less than 70 by definition is hypoglycemia. And then that could be due to excess insulin. So if they're a type 1 diabetic, or if they're using insulin for their type 2, if they've skipped a meal, or if they're really cutting their caloric intake down to try to lose weight, if they're exercising excessively or excess alcohol intake, all those things can lead to hypoglycemia. And then educating them about symptoms. So it can range from mild to severe. If it's mild symptoms, what do they do? So educating those patients, right? Drinking juice, that 15 gram of carbs every 15 minutes, checking their blood sugar every 15 minutes, having candy on them, having something on them so that if they do become hypoglycemic, they can treat that right away. You need to educate your patients about that. A glucagon emergency kit. So if you do have patients on insulin, or patients that you're worried about with hypoglycemia being a big risk, maybe they're on medications with a lot of hypoglycemic side effects, you want to make sure that they have a glucagon emergency kit. And basically the way I describe that to my patients is it's the EpiPen for their diabetes. So if they're passed out, unresponsive, a family member or friend needs to know how to administer glucagon to them via IM or intranasal. So making sure that they do have a glucagon emergency kit at home, at work, at school, wherever it is, and family member, somebody knows how to use it and when to use it is going to be really important. And then lastly, I always like to say prevention, prevention, prevention. So trying to help those diabetic patients, making sure they're maintaining those blood sugar levels at goal so that we prevent hypoglycemia, right? So we also, just like hyperglycemia, we don't want to go too low either because that is also dangerous. So just little pearls for your clinical practice and boards. We're going to do 2 practice questions and then we're going to open it up to a lovely Q&A at the end here. So stick with me, you're doing great. The nurse practitioner is planning treatment for an 89-year-old patient with vascular dementia, hyperlipidemia, hypertension, and type 2 diabetes. Which of the following is the best goal for her glycemic control? So look at the whole picture. You have a geriatric patient and they have comorbidities. Is it A, you want their A1C less than 6.5% and their glucose in range 70% of the time? Is it B, less than 7% in range 50% of the time? C, less than 7.5 in range 70% of the time, or D, less than 8% in range 50% of the time. So again, geriatric patient, comorbidities, including vascular dementia, how aggressive do you want to be with their blood sugar control? So I love it. You guys are doing great. So absolutely listening, and you're going to be safe clinicians. I know it. D is the right answer. You want to back off of this patient, right? They already have cognitive impairment. So you want them to be about 8%, 8.5% is a good goal for this patient. And in range, about 50% of the time is really good goal. The rest of them are just too aggressive for this patient. So again, safety, they want to make sure you're going to be a safe clinician. So last question, primary care providers must screen for health conditions, treat health conditions and diseases, practice prevention medicine. In addition to knowing the schedule of vaccinations to prevent disease, it's critical to stop the spread of contagious conditions. It's kind of a wordy question. Meanwhile, the knowledge of a multitude of type 2 medications is needed to control glucose levels and prevent complications. When a patient presents with type 2 diabetes, what medications should be prescribed first? So basically, they're saying, what is the first line for your type 2 diabetic patient? Is it A, glipizide, B, dapagliflozin? Is it C, sitagliptin, or D, metformin? So what is your first line therapy? I love the participation. That's great. And this is a good wrap-up slide because we talked about all these medications. We talked about what's going to be your first line, and then you're going to add some of these other agents and look at the side effect profile. So if you said D, metformin is your first line, that's absolutely correct. So metformin is going to always be your first line along with lifestyle modifications. And then your glipizides, your sulfonylureas, that's not going to be your first line. Again, hypoglycemia, weight gain, those are going to be the biggest side effects of sulfonylureas. Your SGLT2s and your DPP4 inhibitors, again, you're going to have a lot of different side effects to think about when you're starting patients on these medications. They're not going to be your first line. You're also going to be limited based on insurances and what's going to get improved. So looking at the overall picture for this patient is going to be really important. First line is always metformin and lifestyle. So you guys did great. I really appreciate your hanging in there. I know it's a dense topic, but you did a really good job. And I want to encourage you to go into our Q bank. So I pulled questions out just to emphasize my point on certain slides after we talked about certain medications and certain things, just to help it stick in there a little bit better. But that Q bank is really great because the more you practice, the easier it's going to be. You learn a lot from the rationales. And every day, every week, we put new questions in there. We have over 1,500 in there. They do a free trial. Archer's awesome. They do a free trial, and it's only $29 for a 60-day access. So it's amazing to me. And then if you have your board scheduled in 2 months, $29, and you just practice as much as you can, it seems like a no-brainer to me. But we appreciate you guys signing on to these webinars and learning with us. And we want to help support you in not only passing your boards, but also entering your clinical practice. So go on there and try out the free trial and see if it's something you want to sign up for. We also have a live day 3 review coming up. Registration's open. It's only $50. It includes all 3 days. If you can't join us live, you do have access for 30 days to the recordings. So you can go on, register, and then just have the recordings on the back end if you can't be present live in those 3 days. If you can join us live, that's a good time for you to ask your questions, study, and ask us anything from that particular topic that we're presenting on to anything Archer would be great. And then as always, go ahead and scan this QR code to sign up for all our free webinars coming up. And then you can follow us on social media. Don't forget about those giveaways this week. And then email us with any specific questions you have about Archer, about our product, or just about the test in general. We're here to support you as much as we can. So definitely don't be shy. And I'm going to now open it up to any questions anybody has. I know we're at the top of the hour, so if you have to log off, don't worry about that. But if you can hang in there for a couple more minutes, I'm here to answer any questions you have. Okay, I think everyone's just digesting all the material. So if nobody has any questions, I'm going to go ahead and end today's webinar. Thank you again for joining me today. I have a lot of fun with you guys, and I love the participation, and I hope to see you again next time. So have a wonderful day, and we'll see you again.